Artificial intelligence may help in predicting the need for additional surgery after endoscopic resection of T1 colorectal cancer. Introduction. A recent study found endoscopic resection of T1 colorectal cancers, CRC, to be acceptable before open surgery. Although local excision is an attractive option for T1 CRCs, lymph node metastasis, LNM, is present in approximately 10% of these patients, who therefore subsequently require surgical resection with lymph node dissection. Decisions about further surgery for such patients are made based on the results of histopathological examination of the endoscopically resected specimen and are usually in accordance with established guidelines for treatment, such as those of the National Comprehensive Cancer Network, NCCN, the European Society for Medical Oncology, ESMO, or the Japanese Society for Cancer of the Colon and Rectum, JSCCR. However, these guidelines accurately predict LNM in only 8% to 16% of patients. Thus, most patients without LNM routinely undergo unnecessary additional surgery with an associated postoperative mortality rate of 3% to 6%. Therefore, minimization of these unnecessary additional surgical procedures is urgently required. In previous studies, it was difficult to identify the patients who were actually at risk of developing LNM, even when several predictive models were used. To overcome this problem, the authors focused on artificial intelligence in the form of a support vector machine, SVM, which provides one of the best types of supervised machine learning and is widely used for classification. If patients with a low risk of LNM are identified, no additional surgery after endoscopic resection may be an acceptable option. The aims of this study were thus to use artificial intelligence to develop a high-performance prediction model for LNM in PT1 CRCs, to quantify the associated reductions in unnecessary additional surgery, and to compare the accuracy of prediction of LNM with those of the NCCN, ESMO, and JSCCR guidelines. Background and study aim. Decisions concerning additional surgery after endoscopic resection of T1 colorectal cancer, CRC, are difficult because preoperative prediction of lymph node metastasis, LNM, is problematic. The authors investigated whether artificial intelligence can predict LNM presence, thus minimizing the need for additional surgery. Patients and methods. Data on 690 consecutive patients with T1 CRCs that were surgically resected in 2001 to 2016 were retrospectively analyzed. The authors divided patients into two groups according to date. Data from 590 patients were used for machine learning for the artificial intelligence model, and the remaining 100 patients were included for model validation. The artificial intelligence model analyzed 45 clinico-pathological factors and then predicted positivity or negativity for LNM. Operative specimens were used as the gold standard for the presence of LNM. The artificial intelligence model was validated by calculating the sensitivity, specificity, and accuracy for predicting LNM and comparing these data with those of the American, European, and Japanese guidelines. Results. Sensitivity was 100%, 95% confidence interval, CI, 72% to 100% in all models. Specificity of the artificial intelligence model and the American, European, and Japanese guidelines was 66%, 95% CI, 56% to 76%, 44%, 95% CI, 34% to 55%, 0%, 95% CI 0% to 3%, and 0%, 95% CI 0% to 3%, respectively, and accuracy was 69%, 95% CI 59% to 78%, 49%, 95% CI 39% to 59%, 9%, 95% CI 4% to 16%, and 9%, 95% CI 4% to 16%, respectively. The rates of unnecessary additional surgery attributable to misdiagnosing LNM-negative patients as having LNM were 77%, 95% CI 62% to 89% for the artificial intelligence model, and 85%, 95% CI 73% to 93%, p less than 0.001, 91%, 95% CI 84% to 96%, p less than 0.001, and 91%, 95% CI 84% to 96%, p less than 0.001 for the American, European, and Japanese guidelines, respectively. Conclusions. Compared with current guidelines, artificial intelligence significantly reduced unnecessary additional surgery after endoscopic resection of T1-CRC without missing LNM positivity.